A very good morning to all students. I welcome you to your perio lecture. So today's class is going to be on periodontal regeneration. So the contents of today's class are going to be a brief introduction. Then we'll have a look at some of the topics of regeneration, repair, reattachment, and new attachment. We'll have a brief glimpse on the Melcher's concept, the GTR, GBR, bone grafts, followed by conclusion. Now, if I were to ask you to guess which is this beautiful creature that is smiling at you through your screens, what would your answer be? I'll give you a hint. This is also called as the master of regeneration. This is nothing but the axolotl. Now, the axolotl is very important from scientific point of view because this has the awesome power of regeneration because it is the only vertebrate that can replace any part of its body innumerable number of times. So that is the power of regeneration these axolotls possess. Unfortunately, we as human beings are still a long way from reaching that stage. Maybe someday with good researchers we will be there. What exactly is regeneration that we talk about? So it is a continuous physiologic process. It is the growth and differentiation of new cells and intercellular substances to form new tissues or parts. This takes place by growth from the same type of tissue that has been destroyed. So very important, it is the same type of tissue that has been destroyed or from its precursor. So that's about regeneration. Now let's see what is repair. Now healing of a wound by a tissue that does not, very important, does not fully restore the architecture or function of that part. So we knew in regeneration in the previous slide, regeneration is something where you have the complete reconstruction, whether it be in its physical or its functional form. But repair is simply healing by scar, right? So that's the basic difference between regeneration and repair. Now just let us just look at what reattachment is. So as the name itself is saying, re and attachment. So re means again. So this word re stands for again. So attachment, that is happening again. So very important that this kind of a reunion, okay, the reunion of epithelium and the connective tissue with the root surface when they have been removed in the course of treatment. For example, if you're doing a flap surgery, you need to reflect the flap. And if you need to reflect the flap, you need to give incisions. So when you're giving incisions, you're reflecting the flap away from the bone. So when it is a clean cut or it is an injury, then what we get is reattachment, right? What you get is reattachment. Now, what is new attachment? As the name itself is saying, new. So it is the embedding of new periodontal ligament fibers into new cementum and attachment of the gingival epithelium to the tooth surface. Very, very important. Previously denuded by disease. This is the key word here. So if you remember what reattachment was, it is repair in the areas not previously exposed to the pocket. So when there is positive disease, then it's going to be a new attachment, and when there is a clean cut injury, that's what's going to be reattachment. Okay. So how does this regeneration basically take place? Now, when you talk about the periodontium, you have the four periodontal healing tissues. So as the name itself here, it's numbered 1, 2, 3, and 4. So what is this first compartment? The first compartment is nothing but the gingival epithelium. This one you can observe here. So the second compartment, this one here in pink, is what you call as the gingival connective tissue. This compartment number 3 is your alveolar bone, and compartment number 4 over here will be our periodontal ligament fibers. So you have a total of 4 compartments, the first one being your epithelium, second is your connective tissue, third would be your alveolar bone, and the fourth one, last but not the least, your periodontal ligament. So now in 1976, there was this very famous person called as Melcher. He's a very famous scientist. He is the one who put forward what is known as the Melcher's concept or the tissue compartmentalization hypothesis. Now, what according to him was this theory? Now, according to him, the root surface can be repopulated by four different type of cells. Now, we already saw these four cells, right? The first one was our epithelial compartment, second was our connective tissue, third was alveolar bone, and the fourth the periodontal ligament. That's what is shown in the picture over here. So, according to him, whenever there is a disease, supposing before the disease, you had your epithelium, you had your connective tissue and your alveolar bone along with your periodontal ligament fibers all in their correct places. But now, because there has been a disease, there is deficiency of all these four compartments. Remember, this was compartment number 1, this is 2, this is 3, and compartment number 4. So you can see that there is a defect here. There is, because of disease, certain tissues have been lost. So what happens when compartment number 1, your compartment number 1 is your epithelium. So what happens when your epithelium is the one which is repopulating the root surface, right? So when it is epithelium which is repopulating the root surface, you can observe here, this is the pink thing going right up till here. Then this kind of healing is going to be healing by long junctional epithelium. Why? Because the junctional epithelium is much longer than what it was supposed to be, what you find in normal circumstances. So that is what you call as healing by long junctional epithelium. Next is connective tissue. So when the connective tissue cells predominate the healing, right? Here it was epithelium. Here the connective tissue cells are predominating the healing. So when the connective tissue cells are predominating the healing, what's going to happen is you're going to end up with connective tissue adhesion and root resorption. Right? You can appreciate here that this surface of the root is being resorbed and in fact it is being replaced by your connective tissue. So the third scenario wherein your bone is the bone cells are the one that are going to occupy the compartments. So what's going to happen if it is direct bone? It's going to contact your tooth with no periodontal ligament fibers. So such a condition wherein the root surface is in direct contact with the alveolar bone with no intermediary periodontal ligament fibers, this kind of a clinical scenario is what you call as ankylosis, right? So if the epithelium, now the epithelial cells are the first ones to repopulate the wound because they are the fastest growing cells. So if the compartment number 1 was to repopulate, you get long junctional epithelium. If you have connective tissue, then what you get is by connective tissue adhesion and the root resorption. Compartment number 3 would be your alveolar bone, right? So if it's your alveolar bone, you're going to land up with ankylosis. But what is the ideal case scenario? Now see, in the ideal case scenario, what we are targeting is at regeneration, right? We are targeting at regeneration. So in regeneration, all the four compartments are going to occupy their own spaces. So nobody is going to encroach into anybody else's compartments, each compartment neatly forming where it was at the pre-disease levels. And this is what we called as regeneration. So now we saw with the differential participation of different compartments. We saw the participation of epithelium, connective tissue, alveolar bone, and a periodontal ligament. Okay, with that concept in mind, with the Melcher's concept in mind, let us look at what is GTR. GTR standing for guided tissue regeneration. So in 1996, World Workshop of Periodontics defined the GTR as a procedures attempting to regenerate lost periodontal structures through differential tissue responses. Again, the same thing, differential tissue responses meaning the Melcher's concept. That means the different compartments working together to form the reform rather the periodontium. Now, Gottlow was the first one who coined this term. So what basically is this GTR? Now GTR, as I told you, works on Melcher's principle of compartmentalization, which had a four compartments. Remember the four compartments, 1, 2, 3, and 4. First one being epithelium, second connective tissue, third your bone, and fourth would be your periodontal ligament compartment. So Melcher, what he suggested was, out of all the four compartments, it is the periodontal ligament which is the key to new attachment. Why? Because periodontal ligament, this one, it connects your bone to your cementum. So it provides a continuity between your alveolar bone and cementum, and also because it contains cells that would synthesize and remodel the other three connective tissues of the alveolar part of the periodontium. So according to Melcher, out of all the four compartments, the periodontal ligament compartment was the one which was the most important. Okay, so what are the objectives of GTR? Why do we do this GTR? So we do this in order to give preference to cells that repopulate the wound and have potential to regenerate the tissue. Now, in our previous slides, we already saw that the PDL is the compartment that holds the key to regeneration. So we would love to block the epithelium, the connective tissue, and the bone cells from entering in or encroaching into other spaces, and form a neat barrier so that all the cells get their turn to form the compartments in their respective spaces. Also to exclude, remember, giving preference to repopulate would be your PDL cells, and exclude, that means you want to block. What you want to block? You want to block the fastest growing cells, that is your epithelium and your connective tissue cells out. Okay. Next is creating sufficient space to allow for formation of desired tissue, and of course to protect and stabilize the clot. Now see, in this figure you can very well appreciate it. We have given an internal bevel incision from your gingival margin to the crest of the bone, right? And this is a disease pocket epithelium which we cut out and incise and remove. Now when you form this, when you place this, okay, this is what is your GTR membrane. We place a GTR membrane to physically block these epithelium and connective tissue cells from encroaching into this space and allowing the periodontal ligament cells to repopulate the wound area. Simple? Right. So let's have a look at both the scenarios. So here you can see that there is subgingival calculus accumulation. So what's going to happen now? So either you do a simple flap curettage. So once you are done as curettage, you have removed the disease pocket epithelium here. And what's going to happen now is the flap is going to reapproximate to the tooth tissue. So what's going to happen, as I told you, this is the fastest growing, so this is going to encroach into this area. See, this epithelium has encroached into this area, and this is healing by long junctional epithelium. Now healing by long junctional epithelium or by connective tissue or by alveolar bone are all modes of repair. They are not regeneration. So what we as periodontists target, or we would love to have, is regeneration, not repair. So if we want to have regeneration, we have to block this physically. So we have to place a GTR membrane and block this area so that epithelium and connective tissue cannot encroach into this space, and the periodontal ligament fibers and alveolar bone form their neat compartments. Right? So now when we spoke so much about GTR, let's see what are the different types of membranes. You would be wondering how they look like. So this is how a GTR membrane looks like. Both of these are examples of GTR membrane. So now GTR membrane could either be absorbable or it could be non-absorbable. So these absorbable barriers usually have an advantage of skipping out on your second stage surgery. But if it is non-absorbable, they serve equally good, in fact much better. But the only disadvantage in non-absorbable barriers is you have to go in for a second stage surgery and remove those barrier membrane because they are non-absorbable. So under non-absorbable barriers, you have your millipore filters, rubber dam, EPTFE, that is ethylene polytetrafluoroethylene membranes, or your ethyl cellulose. Now this is how a non-resorbable barrier membrane looks like, and this is a resorbable barrier membrane. So now resorbable could be either natural or they could be synthetic. If you're going for natural, basically and mostly they are formed with collagen. So it could be either perigide, cholesterol, duromatter, or any of the above. Also, when you see among synthetic products, you have your polylactic acid derivatives, or you could have PLA, that is polylactic acid, along with polyglycolic acid combinations. Right? So let me just run you through a small case presentation so that you have a better idea of understanding. So you can see this is pre-op photograph. You can see that the gingival margins are inflamed here, right? Here what you've done is you have reflected the gingival margin, and this what you see here is your alveolar bone. Now pre-surgery, in normal case, the alveolar bone is supposed to be here, say about 1 or 2 mm below your CEJ. But now see, there is so much of bone loss that's happened over here. So what do? We place a bone graft. See, now we are going to follow this up with a GTR membrane. Remember I showed you this is your GTR membrane, and then you suture it back. Now, about 6 months to 8 months post surgery, when you do a re-entry, you can see this beautiful formation of bone. Just compare this and this. So you see the beauty of regeneration which we achieved here when you use proper bone graft and you use a GTR membrane. Okay, so now I'm sure we're clear with what is GTR. Now let's look at what is GBR. Now as this was G, guided tissue regeneration, the same thing GBR would be guided bone regeneration. Okay, so this concept, I'm sure you're clear that you've placed the barrier membrane, blocking out epithelium, blocking out connective tissue, and allowing these to repopulate. This is very clear. This is GTR. Now let's see GBR. Now GBR is much simpler than your GTR. Now in GBR, you are aiming to only grow bone. Okay, guided bone regeneration. So you are only interested in growing the bone compartment, the compartment number 3, that is your alveolar bone. You are only interested in growing the bone compartment. So what's going to happen? See this gray area here, this is your barrier membrane, and you're only interested in the bone forming here, whereas your epithelium connective tissue is blocked out. So when you compare GTR and when you compare GBR, you happen to see that here in GBR, the wound is completely covered by flap, correct? See here. But here there is an opening. So this is an open wound system, whereas GBR is a closed wound system. Now in GBR, since it's a closed wound system, it has sterile conditions. But in GTR, sterile conditions cannot be maintained, obviously, because it is an open channel. Here the membrane is stable, here membrane stabilization is difficult. Same thing, adaptation of the membrane is easy, whereas here in GTR it is difficult. Here the space making is easy and here space making is difficult. This has high predictability, this has low predictability. All the points are almost interrelated to each other. Because it is a closed system, because there are sterile conditions maintained, that is why it has high predictability. Because it is an open wound system and sterile conditions cannot be maintained, so that is why it has low predictability. Fine. So now we are clear with regeneration, repair, new attachment, reattachment. Then we went through Melcher's concept and we have seen all the compartments. We have seen what is GTR, we have seen what is GBR. Now let's have a look at a bone graft. So what exactly is a graft? Now a graft is a viable tissue. Viable means living. Graft is a viable tissue that after removal from a donor site is implanted within the host tissue, which is then restored, repaired and regenerated. I'll just give you a glimpse in a little while. So why do you need a bone graft? Why do we need? So that is for definitive elimination of periodontal pockets, to strengthen the weakened support of the tooth, to increase the ability of periodontium to withstand functional stresses, maintenance of arrested pocket defect, and to produce uniform gingival contour. So what are the objectives? Why do we do it? So it acts as a space filler. Also, it helps to stabilize the blood clot, and of course, as we saw, it supports the soft tissue walls of the periodontium. So what are the secondary objectives? Those were the what we saw previously were the primary objectives. So secondary objectives are PD reduction, that is your probing depth reduction, clinical attachment gain, regeneration of the bone, new bone, cementum and PDL, also preventing epithelial downgrowth. So where all should we go ahead and do the bone grafting? So you could do a bone graft in deep intrabony defects which are associated with chronic inflammatory periodontal disease, to increase bone support for a tooth to restore functional stability as in case of an abutment tooth, to maintain aesthetic gingival margin, height in anterior bony effects. See, basically gingiva is a soft tissue. So for it to form or for it to take any shape, it needs adequate amount of bone below. So because it is going to take the shape of the hard tissue that is supporting it. So what are the ideal requisites of your bone graft? So it should be biologically acceptable, clinical feasibility, meaning you should be able to use it in your clinics. Minimal post-op hazards for the patient, no side effects, minimal post-op sequelae. Patient acceptance, easily obtainable and relatively inexpensive. So what are the different types of bone grafts? The first one is autograft. So auto means self. So autograft means graft that is obtained from one's own self. So the tissue that is transferred from one place to another in the same individual. So the key word here is auto, self and same individual. So what is allograft? Allograft is also known as homograft. Now allograft is the tissue that is transferred between individuals of the same species. So the keyword here is same species. That means human to human, right? So it's going to be transfer between the same species, but with non-identical genes. So see, there is one more thing. There's something called as isograft. So isograft is in identical twins. So where the genetic material is shared. So when you are transferring, taking the tissue from one twin and harvesting it into another, that is what is called as isograft. But if they are non-identical or they are not twins, then we will call it allograft. Next is your xenograft, xeno or your hetero. That means transferred between members of different species. Keyword here is different species. For example, it could be bovine origin or it could be porcine origin. So it is not the human species. Next would be alloplasts. Alloplasts are inert foreign materials which could either be natural or synthetic. So just to revise, we had an autograph that was a cell from one person to from himself, from the patient itself to themselves. It is grafted. The second one is your isograft, wherein you have the same species. In fact, you go one step ahead and have the identical set of genes. So that is your within twins is your isograft. Then you have your allograft. Allograft means same species but non-identical genes. Then you have your xenograft. Xenograft stands for hetero or some members between the different species. Then you have your alloplasts, which are your inert foreign materials. So what exactly is the mechanism of bone formation? So bone basically forms by mainly three mechanisms. One is osteoconduction, one is osteoinduction, and then you have your osteogenesis. So let's look at the first one, that is your osteoconduction. Now osteoconduction is nothing but the formation of bone by osteoblasts from the margins of the defect on the bone graft material. Now supposing this is your bone defect. So what's going to happen is you have filled this with your bone graft. So this is a inert material. Osteoconduction, this mechanism is basically only by your physical means. So it is only physically filling the space here. It's just forming a template for the new bone to form, right? It's just bridging the gap between this and this defect. So in osteoconduction, it is basically a physical property wherein the bone graft is just occupying the space or forming a scaffold for new bone growth. Osteoinduction. Now, as the name itself is saying, induction. What happens here is, see, again, this is your bone graft and this is your bone graft materials. Osteoinduction, here, the bone graft materials will induce the cells to form osteoblasts. So, these particles which are contained in the bone graft are going to not only occupy the space, they are also going to induce the neighboring cells to form into osteoblasts and lay down bone. But for this, we need to add some extra features into this bone graft, right? So what are those extra things? They are your bone morphogenic proteins and your growth factors. So whenever graft is enhanced or it is enriched with BMPs and growth factors, it becomes a osteoinductive graft. So let's look at the last, that is your osteogenesis. Now again, this is the same bone defect and this is your bone graft. Now this is the most ideal condition. Now what happens here is these bone forming cells are contained in the graft material itself. So the graft material itself will lay down new bone, right? So the new bone will be formed by the cells that are contained in the graft itself. And this excellent property is only and only got in autogenous grafts. So those grafts that are obtained from the same individual, right? So these are the only ones that have living cells and have the beautiful property of forming the bone themselves. So we saw osteoconduction, osteoinduction, and osteogenesis. Conduction would be your physical property, merely blocking the space. Induction would be chemical, wherein it is inducing new bone formation. Osteogenesis, genesis means to give birth to something new. So osteogenesis would be the bone graft materials themselves forming new bone. So as we saw, osteogenic means the cells itself are forming the bone. Conductive means physically just forming a physical barrier or a scaffold. And osteoinductive means you have certain additive factors. So under osteogenic, you have autograft. As I told you, the only graft that has the osteogenic potential is your autograft, and this is your gold standard of grafting. Next is osteoconductive. You could have allograft, xenograft, or alloplast. In osteoinductive, you could have autograft or allografts. So let's have a look at the brief classification of the bone grafts. Now it could be either human bone or it could be bone substitute. So if it is human, then it could be either autogenous, that is from self, or it could be allogenic, that means from same species but non-self. So if it is self, then it could be either from extraoral or from intraoral sources, and if it is allogenic, it could either be fresh frozen bone or freeze-dried bone allografts, or it could be DFDBA. Now DFDBA is demineralized freeze-dried bone graft. Now see, whenever the bone graft is demineralized, okay, when the minerals are broken down, what's going to happen? These proteins are going to be exposed, and these are the growth factors. So demineralization will turn the osteoconductive bone graft into osteoinductive, right? Now next, bone substitutes could be either xenografts, that could be either bovine, or it could be corals, or it could be porcine, or it could be alloplastic, that would be either polymers or ceramics or bioactive glasses. So what are the possibilities of bone grafting? What are the different things that you're going to achieve when you do a bone graft? We could see that the bone grafts are actively forming bone, remember, osteogenesis, or they are inducing, that means osteoinduction, or they are creating a passive space, that is physical blocking, so that is your osteoconduction, or it's providing a mechanical obstruction. So, with this huge chapter that we saw, let's just arrive at a conclusion. Although complete periodontal regeneration is still unpredictable, right? With any of the things that we use today, still getting 100% or achieving 100% regeneration is still a mighty challenge. But as we are progressing, as more and more researchers are coming up, we are very close to reaching, maybe not axolotl stage, but of course, somewhere close to that, hoping to have better regenerative materials in our future. Also, Melcher, to sum up, remember that periodontal ligament is the key to our new attachment formation. One, because it forms a continuity between the alveolar bone and cementum, and also because it has cells which can form the other compartments. So new attachment with bone regeneration is the ideal outcome of any periodontal therapy. So I hope you understood, and I hope that there are no doubts as of now. If at all, please feel free to reach out to me. And here's wishing you have a great day. Thank you.